also the events manager. And today I will be co-chairing this session with another member of our inner circle in SAWHE, Dr. Saima Rahman Khan. Just to let you know then, the intention behind the research series is really for us to gain knowledge, to see what everyone's doing in terms of research work, and to hopefully form some connections for possible future work or just, future connections wherever it may take us. We'd like to amplify the voices of South Asian women and the brilliant work that everyone's doing. And obviously within the 6 months that we have this series, we can only do a small number of individuals. We endeavour to build a supportive academic community across disciplines and within disciplines. And I hope you enjoy some of the different talks that we have planned for this series. So without any more from me, I'm going to pass over to Saima, who will introduce our speaker for today.
Thank you, Rumi. And good morning, everyone. My name is Saima, and I'm the founder of the South Asian Women in Higher Education Network. And I also work as a research project manager in the NHS and the University of Manchester. And today it is a pleasure to co-chair the session with Rumi. And it's also delighted to welcome a fourth speaker of this researcher series, Dr. Moonisah Usman from the University of Westminster in London. So Moonisah is a principal investigator of the Westminster Genome Health Hub, which is a transdisciplinary initiative which integrates biomedical, architectural, and social approaches to addressing health inequalities in urban communities. Alongside her research, Moonisah is a committed educator and advocate for socially just and anti-racist practices in higher education. And she brings with her extensive leadership and publications in student-facing and staff-facing partnerships, as well as curriculum transformation. And Moonisah's scientific research has provided mechanistic evidence that link adiposity to reduced vitamin D levels and oxidative DNA damage. And more recently, has used biobank data to identify hyperlocal urban determinants of vitamin D deficiency across London. I will let Moonisah explain that more clearly when she does the session. So Moonisah in this session will explore how biological susceptibility, urban design, and social deprivation converge to impact vitamin D levels, and how and what this means for ethnically minoritized communities. Over to you, Moonisah, to elaborate and share with us about your research. Thank you for joining us today.
Thank you, Saima. It's such an honor to be here. Assalamu alaikum, everyone, and Ramadan Mubarak. It's probably one of the very few talks that I'll get to start with that, so I must take the opportunity. Thank you for the wonderful introduction. So I am sharing today some of the early work from the Westminster Genome Health Hub, which draws upon data from the UK Biobank. And for this talk in particular, I've tried to focus on what these results mean, or what this project means for South Asians. So just a bit of background on vitamin D. Vitamin D is a steroid hormone that has a primary role in the maintenance of calcium and therefore impacts our bone health. So essentially, it allows more calcium to be absorbed from the gut, and it allows calcium to be mobilized from our bones to regulate bone health. However, the receptors for vitamin D are very diverse. And so there are lots of studies that have shown that vitamin D plays a role in regulating cell division and differentiation, and therefore it also has a role in genomic health. Now, most of the vitamin D that we get is derived from the sunlight. So 80% comes from exposure to sun, in particular the UVB rays, which are absorbed on the surface of the skin and lead to the precursor vitamin D, which is then activated by the liver. We do get some from our dietary sources, for example, through consuming oily fish, cod liver oil, fortified foods, which can look like milk or yogurt, or by taking supplements. Now, vitamin D is a heavily researched topic, and interestingly, last summer there were several articles about the rise of rickets, which is essentially a Victorian disease because it was eradicated once we were able to pinpoint the cause directly to vitamin D deficiency and therefore calcium deficiency. But interestingly, the rates have been increasing in the UK. So making vitamin D a very important ongoing topic. Also because the association or the impacts of vitamin D deficiency are very remarkable and again, very diverse. So not only has it been linked to rickets in children and osteomalacia or bone pain, osteoporosis and muscle weakness in adults, but vitamin D deficiency in mothers can increase the risk of gestational diabetes, toxemia of pregnancy, and also small for date births. During the pandemic, there was a lot of research about vitamin D, and it's been linked to several respiratory viruses, including COVID-19, but also with certain cancers, colorectal cancer, breast cancer, and interestingly, other chronic diseases that include dementia and cardiovascular disease. So there are several reasons why we should be interested in vitamin D and its deficiency, but most importantly, vitamin D deficiency is highly prevalent across the globe. So we can categorize the deficiency according to the NICE guidelines, the National Institute for Clinical Excellence, and they derive these figures based upon bone health. So essentially, for adequate bone health, you would need to have vitamin D levels above 50 nanomolars. Insufficiency is below that, and deficiency is below 25 nanomolars. So hypovitaminosis D or vitamin D deficiency is highly prevalent across the globe. We can see that 40.9% of the US, 37% in Canada, 40% of Europe. But what's really interesting is that even in predominantly sunny countries, there are high rates of vitamin D insufficiency. Now, theoretically, with the amount of sunshine they get, this is really alarming. So over 70% in Bangladesh, 90% of UAE, over 80% in Brazil, and over 45% in Thailand. And what this really suggests to us is that vitamin D deficiency could be a public health issue. And I will talk about some of the narratives that have been described as causes, and particularly skin color and behavioral practices. But the spread of vitamin D deficiency across the globe really shows that there could be a public health element to this. Now, my research is focused on the UK, being situated here. And so particularly here in the UK, 1 in 6 adults and 1 in 5 children are vitamin D deficient. And as you can see, the figures are alarmingly high amongst Black Britons and particularly South Asians. So more than half of the South Asians living in the UK have vitamin D deficiency. Now, what are some of the general causes of this? Dark skin. So as we know, melanin is the skin pigment that we have. And melanin plays a biological role because it blocks the absorption of UVB. Now, really, that's a protective factor. It protects us against cancer from the sun and premature aging. But it does mean that we need longer time in sunshine to be able to generate enough vitamin D. Other factors related directly to how much time we spend in the sun, age, so above the age of 70 years, we're at an increased risk, anyone who's had skin graft surgery. But then there are several other factors. So for instance, obesity is linked to a decreased bioavailability of active vitamin D. There are certain drugs that can enhance the breakdown of vitamin D, like anticonvulsants or glucocorticoids. And liver failure will lead to a decreased activation of vitamin D. Now, Public Health England recommends that people take 400 international units of vitamin D per day in winter, particularly those who are from African, Caribbean or South Asian descent. However, we know that compliance is poor. So let's just take a focused look on vitamin D deficiency and South Asians. Now, interestingly, vitamin D deficiency is not a new problem. In the 1930s, it was heavily investigated in India due to rising cases of rickets and osteomalacia, and colonial researchers linked vitamin D deficiency to cultural practices. In their own words, they said, "This practice of parda is deeply to be deplored, since the greater severity of the disease amongst this particular group of the community is direct evidence of the need for ample sunlight to compensate dietic deficiencies." So what they essentially said was that because these disorders could be linked to behavioral choices and biomedical interventions, this was used to justify pressure to assimilate, specifically to push the social and political battle against uncivilized cultural practices, and hardly ever used to highlight the actual social and medical inequities. And this narrative still exists. It's extended to things like a lack of knowledge of nutrition among South Asians. And this dangerous narrative is a part of the problem why we haven't resolved vitamin D deficiency, despite us knowing about this problem for so long. So even in the 1970s, the high prevalence of vitamin D deficiency was noted amongst South Asians living in the UK. And at the time, Professor Riordan and colleagues, they were working in London and Glasgow, and they specifically advised that the fortification of chapati flour, since its wide use, and I'm sure everybody agrees here, it's widely used among South Asian communities, could make a difference to correct vitamin D deficiency. And this advice was put out in the 1970s. However, public health policy did not change towards this. There were other interventions like printing of pamphlets about nutritional knowledge in several different South Asian languages, but it was ineffective. Supplementation of vitamin D, as I said on the previous slide, but we know that again, the supplementation consumption is very poor. So actually only 1 in 6 people that have a deficiency will take the supplement. Now I have this picture of elephant atta up here because just as I was making these slides, I discovered that actually, and I'm not sponsored by elephant atta, just to say, but I just discovered that in 2020, they independently conducted some research and development of this flour, which is fortified with vitamin D. So it was something that they did independently from public health policy or government funding. So this dangerous narrative and this idea that vitamin D deficiency amongst us South Asians is primarily our own fault was quite troubling for me. And I wanted to understand whether there could be some other urban causes, some environmental, potentially modifiable causes, because we can't change our skin color or we don't want to change our religious beliefs, of course. But what can we understand from an environmental modifiable point of view about vitamin D? And it turns out, of course, that the built environment plays a key role in our exposure to sunshine. And building regulations are required to factor in exposure to sunshine. And so the BRE recommends that 50% of garden spaces should receive at least 2 hours of sunlight on March 21st. But there are several factors in the built environment that interfere with this. So for instance, there are studies that have shown that air pollution can block UVB rays from reaching the skin. Then there are studies that have looked at the access to outdoor spaces, touching upon issues such as the distance to nearest safe outdoor spaces. And safety, again, is a big concern, especially with the rise of Islamophobia in this country. So there is potential work to be done there. There's also research that has looked at green space and canopy cover. And this is a very interesting area because green space, some particular types of plants have been shown to absorb air pollution, whereas on the other hand, the placement of trees and the kinds of shade that we create can then have a negative impact on sun exposure. And then there is also some work emerging that links socioeconomic status, particularly deprivation, with low vitamin D levels. And most of this work has been conducted in Dublin. So the aim of my project was then to identify modifiable predictors of vitamin D deficiency at a hyperlocal level across London. So I partnered with colleagues across architecture and social sciences and life scientists to conduct a geospatial analysis of vitamin D. And the hypothesis was that BMI, ethnicity, air pollution, reduced access to green space at the hyperlocal level will be linked with lower levels of vitamin D. So a little bit about how we went about this. So we acquired data from the UK Biobank. If you haven't heard of it before, it's a large-scale biomedical database and a very rich resource containing lots of in-depth genetic, health and lifestyle information from about 500,000 UK participants. So it offers a wealth of data, including blood samples, physical measurements and health questionnaires, but also spanning a wide range of demographic variables, age, gender, ethnicity, socioeconomic status, and so on. We focused on the MSOA level, which is the middle layer super output area, essentially focusing at a neighborhood level that would cover roughly between 2,000 and 6,000 households. And we mapped the data that we had available at MSOA level to the UK Biobank data. And this graph over here shows you the distribution of the final data points after we mapped the data. The air pollution assessment essentially involved modeling of data, and we focused on particulate matter, PM10 and 2.5, nitrogen dioxide, nitrogen oxides, and then we looked at other factors, including traffic, land use, population density. The green space and built environment assessment included modeled data for green space, which was which basically includes access to parks, communal gardens, cemeteries and agricultural land, domestic gardens, proximity of residential addresses to major roads, again an indicator of how much potential exposure there could be to air pollution, and traffic intensity on the nearest major roads. We, of course, then brought in demographic data and looked at confounding factors as well. So gender, very important. There are a lot of studies that show that vitamin D deficiency is more prevalent in females. This could be related to the increase in fat mass, age. We know that over time, cutaneous synthesis of vitamin D decreases. Ethnicity, of course, we know is important due to skin color. Index of multiple deprivation in order to acquire socioeconomic status, the season of blood collection, because we know that obviously winter, less sunshine will have an impact, the type of accommodation that's lived in to give us an understanding, of course, of the sort of conditions that can influence access to sunlight, the opportunities for outdoor activities, number of vehicles in the households to get a broader picture of socioeconomic context, oily fish intake as a proxy for potential dietary intake of vitamin D, and time spent outdoors in summer directly exposed to UVB. So a very sophisticated statistical analysis was conducted in R by our wonderful statistician, but I will just summarize here to say that essentially he created a geographically weighted regression model because it allows us to look at the changing variables across the different regions by applying different regression coefficients. So essentially, the geographically weighted regression module is what allows us to do a geospatial analysis. Okay, so what did we find? So we found that similar to other studies, on average, first of all, across the population that we had access to, vitamin D levels are insufficient. So the average levels were only 20.69. And here is the thematic map of vitamin D across London, which visually represents the spatial distribution. So you can see that vitamin D levels are very different across neighbourhoods across London. And this type of map highlights the varying levels, which really illustrates the geographic disparities in vitamin D. And when we tested this, we found that this is significant. So there is significant spatial clustering of vitamin D across these neighbourhoods. So the next step is to understand what could be the potential predictors of these differences in different neighbourhoods. And what we found are several significant predictors from our model. As expected, body mass index, also low socioeconomic status, and we know that that is linked with things like access to nutritious food, but also access to outdoor spaces, healthcare resources. Nitrogen dioxide, PM10, PM2.5 were all air pollutants that were significant predictors of vitamin D levels, including traffic intensity on the nearest road and proximity to major road. Green space, again, as expected, was also a significant predictor here. Again, that highlights that perhaps more access to green space could be associated with more of an opportunity to engage in outdoor activities and thereby expose yourself to more sunlight. The natural environment percentage buffer and distance to coast, similar theory there with respect to increased opportunity to be outside, but perhaps near the coast, maybe increased opportunity to take in more vitamin D rich seafood as well. Population density and household size as an indicator of perhaps socioeconomic status and maybe reduced access to outdoor opportunities again. So we also conducted hot and cold spot analysis to further find whether there are any specific areas that are significantly different in terms of vitamin D. So here, the hot spots indicate the regions with higher vitamin D levels that were often characterized by better environmental conditions and higher socioeconomic status. And conversely, the cold spots reveals area with lower levels. So we can see, if we look at the hot spots here, we can see over here, for instance, Richmond upon Thames, higher socioeconomic status, also the very wonderful large Richmond Park, maybe having an impact there. And then over here, we have the cold spot, which is more Croydon located, which we also know is more rich in terms of its ethnic diversity. Some further analysis to compare the difference between the hot and cold spots showed that, for instance, here on the left, you can see that the index for multiple deprivation was significantly lower in the hot spots compared to the cold spots. So the hot spots, what that essentially means is that it highlights the role of socioeconomic status, with more deprived areas showing lower vitamin D levels. On the right, green space was a factor. So here we can show that green space essentially is quite important for promoting outdoor activities and sun exposure and for maintaining adequate levels of vitamin D. So overall, our geographically weighted regression model is the first to identify heterogeneity in that relationship between air pollution and vitamin D across London. And it suggests that this may be potentially explained by social and built environment characteristics that are described at that MSOA, that neighbourhood level. And interestingly, many of the factors that are linked to vitamin D are potentially modifiable, including BMI to some extent, green space access, air pollution, and social deprivation. So why is the link between vitamin D and urban forms so important for ethnic minorities? So to circle back, our previous study, which was conducted just after the pandemic, found that total population, the number of residents of Asian ethnicity, 4-year average levels of particulate matter 10, which is a potential, which has some of the most alarming evidence in relation to human health, and road length to be positively correlated with COVID-19 cases and deaths. And we also found that percentage of households with access to total open space negatively correlated with COVID-19 and deaths. So there is a correlation there between these factors linked to vitamin D were also linked to COVID-19 cases and deaths during the pandemic. And then everyone in this room will be well aware with the fact that the pandemic highlighted the disproportionate impact of COVID-19 on ethnic minorities in the UK, particularly amongst the Bangladeshi population. Now, we know in this country that ethnic minorities and in London are more likely to reside in deprived neighbourhoods with reduced access to green space and exposed to high levels of air pollution. And one could take Tower Hamlets as an example of this. And then we also know that obesity disproportionately impacts ethnic minorities, and obesity is also characterised as a social problem. So the question really is that could ethnic health disparities be attributed to such environmental exposure variables and vitamin D deficiency? And of course, I can't answer this question in this presentation. This is very early work, but this is essentially where I want to be heading. And this is where I am looking for collaborators who are interested in doing this sort of work to please do get in touch. So to conclude, the study highlights the complex interplay of environmental, demographic and socioeconomic factors that influence vitamin D in London. And public health interventions should consider these factors, particularly targeting the areas that have high pollution and low green space to address vitamin D deficiency. And we need more research to explore causal mechanisms and develop targeted strategies for improving vitamin D in vulnerable populations like the South Asian and Black communities as well. For future work, I would really like to look at environmental interventions. So which interventions can improve vitamin D in relation to air pollution reduction strategies, looking at building structure and materials, the accessibility of outdoor spaces, but also barriers to outdoor exposure. And I think this kind of work requires an analysis at community level, which is something that we've not got to yet. And again, I'm very keen on understanding what the barriers to the current environment are, and then how they can be potentially modified in a very creative way to allow more South Asian people to have access to safe green spaces where they can enjoy the sunshine. So I'll just end by acknowledging firstly the UK Biobank for provision of the data, and then the University of Westminster Research Communities for the funding, and the academics that have co-authored this work, Evren Rahman, Maria Walashinovic, Rosa Shanafan, and Professor Emanuela Volpi, without this work would have not been possible. And I will leave you with several resources to look at. Thank you very much.
Thank you, Moonisah. That was fantastic. So much information to take away. Thank you, everyone, for being here. Before we go to the chat, and I know there's some questions in the chat, does anyone from within here in this room want to ask any questions directly to Moonisah? You can raise your hands or unmute.